And we will, so just a reminder, this is being recorded. So again, put STACK, S-T-A-C-K, in the chat, and then we will call on you as those STACK chats are entered. So it will be in the order that they are entered. Um, so I think that's it for now. Um, oh, okay. So I'm supposed to tell you to whom you can send your personal info. We will do that at the end, so we will make sure that you have a way to connect with us after this program. That's obviously really important. Okay, so I am going to kick it off by introducing our speaker. We are super happy to have her. Dr. Susan Rogers is the president of Physicians for a National Healthcare Program, and she has a particular interest, and the topic of this session, in health equity. She has been a faculty physician in internal medicine at Cook County Hospital in Chicago and a medical director of a community health center providing primary care to low-income patients. Her caucus will focus on the following questions. What are the inequities in our healthcare system? What changes are supported by the League's positions on healthcare and DEI? And how can we achieve these positions? What can we do as individual leagues and as a statewide league to get closer to healthcare equality for all of us in this country? So a broad topic, we hope to cover a lot. We invite your questions. So one more thing, I'd just like to do a quick shout out. I understand that Carol Moon Goldberg has joined us. She's the president, as you know, of the League of Women Voters of California. So welcome, Carol. We're so happy to have you as well. And with that, I will turn it over to Dr. Rogers, and she will bring up her slides.
Okay. It worked. Great. Okay. Welcome, everyone. It's afternoon here in Chicago where I am, but I thank you so much for asking me to speak to you today. And I'm excited about talking to you about this because this, as Janet said, this is a topic that I am actually quite interested in. And one of the reasons why I went into medicine and trained where I did. But let's get started. And I wanted to start with, oh, I got to do it this way. To start with this particular slide, I don't know how many of you have seen this, but this slide, there's the picture in the background about the world's highest standard of living. That there was a whole group of slides that was made, I think, by the manufacturers union here, or a group, I don't know if it was the corporate part or what, but they made all these posters espousing just the wonderful standard of living the United States has and how it's just so great. And there's nothing like living in America because it's so wonderful. And it didn't really talk about the whole country. It talked about part of the country. And what this picture is, below this is a line of Black people who lived in Louisville, Kentucky, who were made homeless because of the flooding. And here they are in line at the Red Cross in front of this poster, this billboard. So what this is it's saying that there's no way like the American way. And when you think about it, this is exactly what the American way is. This American way that we espouse is so wonderful, has disenfranchised Black people from the very beginning, from the time they were violently brought here from Africa and enslaved to even after the end of the Civil War. There's never been a sense of trying to equalize these two groups in this country. So I want to go through some of the things that have been done to perpetuate these inequities and how it shows up with healthcare. So I think this is a very interesting slide because if you look at this, it compares life expectancy and how much we spend on healthcare in this country and actually in the world. On the left, the vertical graph shows how long people live, and you can see all the wavy lines. Those are countries, mostly industrialized countries from Europe and Asia. And you can see that they are much higher than the line for the United States. The horizontal line, which shows how much money we spend per capita in this country, the United States is far and away spending more than anyone. So here we have this inequity. We have other countries spending much, much less and getting much, much more than the United States. And even on the bottom part of this line, I have the line of Black men and what their life expectancy is. And we are almost 10 years younger than white men in this country. So we are an outlier. And so why is it that we are spending 3 times as much as other countries and getting nowhere near as much? Is that the American way? Because this is really why are we espousing the American way when what we're doing is so expensive and not getting anywhere what we should? So one of the things that COVID really laid bare was the inequities that are occurring in this country. And people seem to be surprised at why are Black people getting so sick from this? Why are they the ones getting sick? Why are they the ones that are dying from it? And this is some data from the early part of the pandemic. And you can see that Black people were dying at 3 to 4 to 5 times the rate of white people in this country. Hispanics were faring just as bad. And it got, there were questions about, well, they have more comorbidities, but nobody asked why do they have more comorbidities? Something genetic about the virus that attacks Blacks and Hispanics more. So it's this question that came up. We've known about these inequities from the beginning, but we ignore them. We consider them normal. That's part of being in this country. If you're Black, you're going to die earlier. That's just the way it is here. And it's not as if something were to be done to fix this. And so it's interesting because this is just what that poster that I showed in the beginning. This is the American way. Now, one of the things I want to bring up is the maternal mortality. And this is separate from COVID inequities, but women in this country are dying at a rate, this is before COVID, this is not related to COVID. They are dying at a rate 5, 6, 7 times as high as some other industrialized countries. Now, the World Health Organization looks at maternal and infant mortality rates almost as a surrogate for the health of a country. So what they're really saying is that the health of America is not very good. And there's a lot of reasons for this. And 2/3 of these deaths actually are preventable. But in this country, we have a lack of midwives. We don't have any other staff to help with pregnant women in a lot of areas other than physicians, where a lot of areas in this country, they don't even have an MD to provide obstetric care. And let's be clear on what maternal mortality, what the definition is. It's defined as death from childbirth or during pregnancy related to a cause during pregnancy, and up to a year after the birth of that child. Now, it's interesting that we look at mortality as a risk up to a year. However, most health insurance policies don't cover you for that pregnancy for more than 6 to 8 weeks after childbirth. So let's say you have a complication that will remain a chronic problem. You still won't be covered for the rest of the time. We are the one of 11 countries. We are the only one out of 11 industrialized countries that does not provide any paid maternal leave. So that we don't look at, it's our responsibility to support women while they're pregnant or support their babies. And so this is part of the reason why the death rate is so, we don't even track mortality. It wasn't until 2003, I think, that there was a box on a death certificate to even check to say if the woman was pregnant or not, so that you could go back and see if this was a pregnancy related death. Even Mongolia has more reliable data related to maternal mortality than this country does. So we don't have a good way to track this. We're not giving support to women who are pregnant to provide them with the health care that they need, to provide them with other supports they need. We don't acknowledge that many women are having careers along with families, and that needs to be supported. And so it should be no surprise that we have this gap, that we have such a worse mortality than other countries. And this is how we break it down by race. And here, Black women are suffering more deaths than white women still. A lot of this is that women, it's been found, there's a condition called weathering. I don't know if you've heard this term before, but what it describes is it's an expression of the stress of living Black in this country. And it's described as a lot of hormonal changes, physiologic changes, biochemical changes that occur. And some of this is normal. It's the flight or fight response. When you get into a situation where you have to make an immediate decision, you have to fight or flight. These hormones and changes come into play to help you respond to that situation. But that should be short lived. It shouldn't be continuous. It shouldn't be part of your daily life to go through these hormonal and physiologic changes to be able to function. So, what happens is people age sooner. And that's what they found with Black women. They found that teenage Black girls tend up having healthier babies than Black women in their 20s and 30s. And they think that this is the opposite actually of white women. Whereas when you get into your 20s and 30s, you are healthier to have a baby. But the feeling is that this is because of weathering, the physiologic stress that Black women suffer from. And it's not just socioeconomic. Look at what happened to Serena Williams and Beyonce. There was a Black pediatrician who was a chief resident who died in childbirth. And I mean, Serena could have bought the hospital she was at, but she still suffered a life-threatening complication because she had to go and fight for herself and insist that she really was short of breath. So part of it is the bias that has been shown in this country that symptoms that Black people complain of aren't taken seriously, their pain is not taken seriously, and Black women who are pregnant are not taken as seriously with their complaints. So that again contributes to the increase in the mortality. And even the babies, the infant mortality is greater in this country with all babies, and even, let me get this, and even with minority babies. Black babies die at over twice the rate as white babies, the infant mortality, and Hispanics are not as bad as Black babies, but there's still more deaths in that group than with white babies. So there's this gap here that persists. So we're all aware of what we call the social determinants of health, and there are a lot of factors that involve in being healthy. And we all know about these, even if it's just casually, if it's not by that term. We all know if we eat better, we are healthier. If we exercise more, we are healthier. If our finances are stable, we can be healthier. So all of these have a play. One of which is healthcare, and whether we have access to healthcare is important into how healthy we are. So this country provides healthcare by insurance. And by insurance, we're talking about private companies that decide whether or not you can get the care that you and your doctor decide upon, which when you think about it is a very unusual situation because it shouldn't be the insurance company who decides what you need. That decision should be between you and your provider. So we have put the insurance company in the middle as a middleman who extorts billions of dollars a year out of this relationship so that they can, and they get this money by not allowing you to get the care that you and your doctor say that you need. So who is uninsured all year? Well, back in the 60s when Medicare and Medicaid became real entities, the uninsured rate dropped. People over 65 were now able to get covered by Medicare. People who were poor were able to get Medicaid. And keep in mind that when we talk about the federal poverty level in terms of who can get Medicaid, the federal poverty level really doesn't define who is poor and who isn't poor. It just creates a marker about who is eligible for this benefit and who isn't. So there's a lot of people who are 2, 3, 4 times make the federal poverty level who are still living in poverty, although they are not eligible for some of the benefits. So that we can see here with this slide that after the Affordable Care Act, the uninsured started to go down again. And after that came into play, but now it's starting to go back up again. And if we look here as how it affected all groups in this country, we can see how the uninsured rate dropped with Latinx, Blacks, whites, everybody. The uninsured rate drops, but there's still a big gap between who is insured and who is not. And especially when insurance is tied to your employment, who isn't eligible for that? It's mostly Blacks and people of color. Most of the jobs that people of color and Blacks have tend to be they tend to be more frontline workers. They tend to be more low wage workers working at poverty levels. They are in jobs that don't provide health insurance. But even with health insurance, we should be clear that being insured doesn't ensure that you have access to care. And we'll get into that a little bit more in just a second. So one of the things that insurance, when the Affordable Care Act came about, they were very focused on the cost of premiums. And there was all of this talk about, well, people need to put skin in the game. They have to come out of their pocket for something. So they don't overuse. I don't know who decides, well, I have nothing to do today, I'll go to the emergency room. I mean, people don't overuse healthcare just because it would be, quote, free. They have other things in their life. People go to the emergency room for real issues. But one of the things that has happened in this country is the deductible. And deductibles have risen way out of proportion compared to income. And we can see that what happens with employer-based insurance, employers pay about 67% of the premium, which means the employee is still paying money. It's not, they don't see that money because it doesn't go into what they bring home, but it's taken out of their salary. It's taken, rather than given to them as dollars for their salary, it's a benefit that they never see because it goes directly to the insurance company. So the average employee pays almost $7,000 that is deducted from their paycheck towards the premium for their health insurance. $7,000 a year would make a big difference to a lot of people who are working every day. And it's also a very regressive way to pay because that average cost per employee is not dependent on their salary. Every employee would pay the same, whether you make $30,000 a year, $60,000 a year, $600,000 a year, you still pay the same for your insurance. So it's a very regressive way to pay. So it's almost like having this deductible means that you have to come out of pocket for a lot of dollars before your insurance even starts to pay. So think about how much this insurance company is getting before they pay a dime for your care. They're getting the employer's 67% of the premium. They're getting your $7,000 a year. They're getting this deductible, all of this before they spend a dime on you. That sounds a bit like a very lucrative plan to me. And that's what it is. So a lot of people never can pay down their deductible. And so the insurance company never pays for them, or they go into bankruptcy. I'll get into that too, about how the impact of a deductible on what people decide to do and not do in terms of getting health care. And the Affordable Care Act, this was a big problem because when they decided to sponsor and subsidize premiums, they didn't think about the deductibles. And the deductibles are often higher for plans that people get through the Affordable Care Act coverage. Now, if you're having your premiums subsidized because you can't afford it, how are you supposed to come up with almost $9,000 to pay for your deductible? It doesn't make sense. The numbers don't work out right. But this is how it's marketed. People don't see that as a deductible. And so what they do is they get a plan that has a low premium, but has a very, very high deductible. So they can't even get the benefit of having a low premium and having an insurance plan that they can use. And so what happens? People have medical debt. It leaves them in financial despair. I mean, many people use all their savings. They take out another mortgage on their home. There's a lot of things that happen because people cannot pay their deductibles. They cannot pay the plans. They cannot pay the other out-of-pocket expenses, the copays, the pharmaceutical costs. So that medical debt leaves people with lingering financial problems that devastate a lot of people. Now, Medicaid did improve healthcare access. That was one of the things that was supposed to be for the entire country, but several states said, no, we're not doing that. And interestingly, the majority of those states were in the South. They chose not to expand Medicare, even though the majority of poor people live in the South. But they chose not to expand. I wonder if that's related to the fact that there's more Black people who live in southern states than in the rest of the country. They chose not to expand. So these states chose not to expand Medicare, which leaves their hospitals having more unfunded patients to take care of. It provides their patients, the people who live there, with less choices or no choices of where to go for their health care. And so what happens when people do get Medicaid, again, it doesn't ensure that you have access, because privatization of Medicaid has so expanded that almost all Medicaid programs are now going through a private insurance company. And so what happens is that you now have networks, you have constrictions on who you can see and where you can see them, what drugs you can get covered. And so a lot of physicians don't even take Medicaid patients because it is so grossly underfunded. It doesn't even cover the cost by any means, whether you're seeing a primary care doctor for a physical or whether you're going for surgery or joint replacement. The payment reimbursement is so low that a lot of providers won't see Medicaid patients. And this is just an expression of how these patients are valued. I mean, you have a system that doesn't even pretend to be about being able to provide them care. So we have a system here with Medicaid where half the providers, half of physicians won't even see them. So that the ability to access this care is really, really restricted. And one of the things that has happened because of the way we finance hospitals and with deductibles is that hospitals are closing. Hospitals need to get paid for what they do. That's this country, this is what this healthcare system does. It functions on profit, but a lot of hospitals can't even make a profit, especially in the rural districts where you have a lot of Medicaid patients and they end up going to hospitals and that hospital can't get reimbursed for their care. There have been a lot of hospital closures that have happened because of this lack of hospitals being able to get reimbursed. One of the things that happens, one thing that has happened is that since 2010, there's been about 180 rural hospitals that have closed. That is leaving gapping deserts of where there is no healthcare providers. And this has really impacted on obstetrical care. There are a lot of counties in the South that have no obstetrician, none. You can't get your prenatal care. You can't get your care if you go into labor. They are just deserts. And when we look at what is the most common reason for hospitalization, it's childbirth. And you've got these areas with no hospitals. And this is directly related to how we finance healthcare. It's through the insurance company, which is made for profit. And if you don't make a profit, you close. And this is happening in rural communities, and it's also happening in urban areas. One of the things too is that a lot of hospitals in poor communities don't have intensive care beds. And this really came to light with the COVID pandemic because so many more people need intensive care. And if you look at what this graph is showing you at the far left, communities where the average income is less than $35,000, 50% of these communities have 0 ICU beds, 0. They may not even have a hospital, but they have 0 ICU beds. If you take a community where the average income is over $90,000, less than 3% of those communities have 0 beds. Most of them have more than 7 beds. So that the inequities that come from the way we finance care and who is able to get it is shown here, especially COVID made that very clear. And if you look at some of the data from New York, and New York was all in the press, and because they were hit so hard in the pandemic early. If you look at the hospitals in Queens and the Bronx and Brooklyn, they had the largest share of cases, but they had the smallest number of well-resourced beds to take care of these patients. And this is strictly because of the way we finance healthcare. If you can pay for it, you get it. If you can't, you don't. Now, one of the things is, so why do we have these communities in the first place? Why are these inequities here? I mean, it's, we hear about, when Obama was president, we're post-racial, it's been 150 years since the Civil War ended, but there's a lot of policies and things that are perpetuated through that enable the inequities to persist. One of the biggest is redlining, and I'm sure this is a term most of you have heard of, and this is just a graph taken from in Chicago back in the 30s when redlining started. Now there was segregation way before redlining started, but what redlining was responding to was when the New Deal started providing enabling banks to insure mortgages. They decided that communities that had any Black people in it were high risk, and so they were not going to insure any mortgages for any homes that were being sold or bought in Black communities, and so those communities were redlined. But even before this took place, when the migration of many Black people, freed slaves, occurred from the South and they moved into northern cities, they were only allowed to live in certain areas. So back then you could say Blacks only, whites only. It's not politically correct to say that now. So there's different ways it gets done. But there were areas that were clearly segregated legally in other cities. And so what happens when you make a group of people have few choices, very limited choices of where they can live, and you also eliminate the main way that families can accrue wealth is through home ownership. What are you creating? You're creating poor communities. You're creating ghettos. They didn't just happen. It's not like a bunch of people got together and said, let's all be poor. This was created. And so, and when we think about how where we live has such an effect on our lives, neighborhoods are where we have access to transportation, we get our education, our employment opportunities. This is where our healthcare is. This is where our grocery stores. This is what provides the infrastructure for people to grow and prosper. And when you have communities that are neglected and purposely not given those resources, what happens to them? They don't thrive. They don't prosper. And this is what has happened. And I think one of the things that we need to understand is that white poverty is not the same as Black poverty. If we look at areas of what is defined as concentrated poverty, and that is areas or communities where 30% of the people who live in that community are poor. That is, they fall below the federal poverty line. Now, that doesn't mean that the people who are above, as I mentioned before, the federal aren't poor too. But so what happens is that, and people end up living in concentrated poverty, but Blacks have no choice of where to live. White people can really go wherever they want, and poor white people are readily accepted in other communities that a poor Black person would not be. And so if you look at what has happened in cities, I'm here in Chicago, 35% of poor Blacks live in communities of concentrated poverty. Whites in Chicago, it's less than 5%. So who ends up getting uneducated? Who ends up living in violence? Who ends up not having a grocery store? Who ends up not having proper sanitation? Who ends up having crowded housing? Who ends up in a community that has no job? This was all planned. This didn't just happen. This wasn't because Black people are in our way genetically, they want to live like this. This was forced. White people have always had choices in this country. Black people don't. And I look at myself, I'm standing in front of you today because I was lucky. Yes, I worked hard, but I was lucky to be able to have an opportunity to work hard. And I think that that's one of the things that gets lost, and that things are not the same for white people and Black people in this country. It's no different from that first slide that I showed that showed the inequities of what is the American way. That is the American way. And this concentrated poverty and differences in Blacks and whites is it's copied in, all over the country. It's not just one place, it's everywhere. And I wanted to show this slide because I think it's important that we see one of the things about structural racism, and that's what segregation is. It's a structural racism, and it keeps Black people in their place where white supremacists want them to stay. It controls them. The police are able to surveil poor Black people once you keep them confined. So what happened after the Civil War and the 13th Amendment was signed? That was when states started, they came out with what we call the Black Codes. And the Black Codes were laws that only applied to Black men. And they were things like you can't walk on the sidewalk, you can't play checkers, you can't walk along the railroad tracks. And that was how people knew they were going the right way, by following the railroad tracks. So it defined and it was not criminal behavior. It was just a reason to arrest Blacks. And what happened was that they had to find a way to sustain the economy on the plantations in the South. So they arrested Blacks, they went to prison, they were leased out as convict labor, and that's who worked the plantations. And the North never did anything about this because, remember, the North was just as dependent on the Southern economy as the South was. So this was a win for the entire country. And that's why this persisted. And so it made the business of arresting Blacks very lucrative. And who were the people who arrested them? The police. And this is how the police forces started arresting Blacks. It was a game. It was what they did, and they saw nothing wrong with what they were doing. And their primary responsibility was to arrest these Blacks to supply the economy. And even children were leased. If their parents, for whatever reason, weren't around, they were leased to plantations. And so this was how it prospered. And this has continued. The picture on the left is from the 1860s, that's when convict leasing just started. Who's in the picture on the right? That's today. And this is what the war on drugs has done. It has repeated what was done in 1866. And so if you look at New York City is 43% white, 24% Black. However, people of color make up 94% of the marijuana arrests, even though the data shows that Blacks and whites use marijuana at the same rate. So this is how, now with the prison industrial complex, and that many corporations now have factories, or they lease prisoners to work in their factories for pennies a day. This is the same thing that's happening now. We don't call it convict leasing. It's got a nicer word. I'm not sure what it is, but this is what is happening today. And so it's Black men whose lives are destroyed, and the country gets rich off of their free labor. And we know how the prisons are when we talk about healthcare and COVID. It was rampant in prisons because it was crowded. There was no way to control the spread of COVID during that time. So what single payer can do, single payer won't solve the police brutality against Black men. It's not going to solve a lot of the inequities that are they're such part of the social structure in this country that it's considered normal now. These inequities are considered normal. You assume that a Black man who gets stopped by the police did something wrong. I mean, how do you stop somebody because they have an air freshener hanging down from their rearview mirror and saying that's obstructing their view and he ends up being killed? How many people who are disabled, who have that thing hanging down get stopped because that's obstructing their view? So they can pick and choose about um, who gets attacked and who doesn't. So one of the things that single payer can do, though, is it will foster quality by making it acceptable to everyone. And there's no question that people who have access to care do better. Now, whether they are able to pay for that access to care, it's been shown that with high deductibles, with high copays, with pharmacy costs, a lot of people, even with insurance, can't pay for their care. They can't pay the out-of-pocket expenses. To me, it's almost like if I give you a car, let's say brand new car, it's got all the bells and whistles, but I don't give you the key until you pay me $8,000. I mean, you don't have a car. You have something that looks like a car in front of your house, but you can't drive it. And it's just like you have a card in your wallet that says Blue Cross Blue Shield or Cigna, but you can't use it because you haven't paid the deductible. So we have to have, if with single payer, it would be everyone would have access and it wouldn't be dependent on your having a job. It wouldn't be dependent on you paying for it. There would be small taxes with your employer, but it would clearly be less than what you're paying now. But this is a system that would be single tier that would foster quality by making it acceptable to everyone. And I've always said, if it's acceptable to white people, then it'll work. And we're talking about all medically necessary services. Now, if somebody wants to pay for a single room with a view of the lake, if that's where their hospital is, they can do that, but they won't pay more for they won't get better care just because they have more money. It would help reduce inequities because we could put facilities where they're needed and not where they can make money. We wouldn't need to have rural deserts. We wouldn't need to have urban deserts. We wouldn't need to have hospitals in poor communities without resources because that community cannot afford to sustain that hospital because of too many are uninsured. The system would provide continuity of care. You could keep going back to the doctor. You could get follow-up for whatever your problems are. Preventive care would be a priority. Right now, this country, less than 10% of this country gets all the preventive care that they should. It would make possible for a unified electronic medical record like the VA has. If you're a veteran and you see a doctor in New York and then you see a doctor in California, they can both see your medical record. And it would facilitate real health planning by putting resources where they're needed and not where they can make money. It's just like putting things where they're needed. I work at Cook County Hospital, and within that 1 mile there's Cook County Hospital, there's Rush University Hospital, there's University of Illinois Hospital, and there's the Jesse Brown VA Hospital. However, 3 or 4 miles away, there is absolutely nothing. So we have all of these facilities together, but then farther away, there's nothing. It's just like putting, 4 fire stations at 4 corners of an intersection. That doesn't make sense. You want the fire stations to be out in the city so that they're equidistant from where a fire may be. And that should be the same with healthcare facilities, if we want to be able to treat everybody. And part of the problem with the reform that is proposed now with so-called improving the Affordable Care Act or the public option based on private insurance, that doesn't solve anything. For one, if we've learned nothing from the pandemic, we know how fragile employment is. And so coupling insurance to your employment is really a fragile and unstable relationship. Your insurers can change your networks, increase your premiums, deductibles. They won't guarantee that you can see the same doctor. And providing more government to insurance companies doesn't lower costs or improve care. It just provides more money to the insurance companies. It doesn't do anything to improve your care. This is why we need Medicare for all. So the inequities that have been made obvious by COVID have already been there. They were there. We just chose not to see them or to blame the victims for their own poor health. but I tried to show you some examples of how they've been created in this country and then made worse by the way we finance our healthcare system. However, universal coverage, publicly accountable, a single payer health coverage is an essential component to resolving some of these inequities, and we'd all be healthier. I think we all have to understand that we will be healthier if everybody's healthier. It, if you're when your children go to school, you want their teacher to be healthy. When you go to a restaurant, you want whoever cooked your food and laid down your silverware to be clean and healthy. Everybody benefits from that, and we have to get over this thing that people who don't have money have no value. And that's one of the crucial points that we have to change. And we have to realize that about whether you are entitled to health care or whether you're entitled to anything, that it can't just be based upon money. And I like this because Shirley Chisholm, who was the first Black woman who was elected to federal Congress back in the 60s, and she said back then that health care was a right. It was felt to be a privilege, as it still is now, available to only those who qualify. But that's the real reason the healthcare system that we have now just isn't working.
Dr. Rogers?
Yes.
I just wanted to jump in really quickly. I'm just trying to be mindful of the time, and your information is so incredibly compelling and far-reaching.
I talk too much.
No, I'm not trying to say that at all. I wish we had another half hour. That will be wonderful. If you could just wrap up real quick so we have a little time for questions, that'd be
my last slide. This is why we're not having any solutions, because the lobbyists in Congress are buying the people in Congress. So although voting is important, we have to stay on who we elect so that we do the right thing. And these are just some websites that are very useful sources of information. And sorry, I talked too long.
No, that was truly wonderful, devastating and wonderful. I have not heard this kind of presentation before that had so many good graphics and statistics that are so really devastating. I think I was looking around at people's faces, and this information is, I think we sort of knew we hadn't really felt it in a compassionate way. So this was really impactful. So we invite questions, please. 2 ways to do questions. You can just put stack in the chat and we will call on you, or you can write your question out in the chat itself. There are a few other people who are part of this caucus who can answer questions. They are Pat Snyder, Janet Thomas, and Hank Abrams. They've all been involved in healthcare for decades and involved in advocacy at the local level, the state level, the national level. So they are available for questions as well. So I'm going to start it off, moderator's prerogative here. I'm going to start it off. And Dr. Rogers, I think one of the questions that many people often ask sort of in a knee-jerk way is, it sounds great to have a single payer. We could get everybody covered with good, high quality, accessible care, but how do you pay for it? And what are the high level, 10,000 foot, what are the things we need to be thinking about in terms of addressing this financially?
What's kind of interesting is that question always gets asked, but we never ask about how did all these other countries, how did they pay for it? And they got better care and better outcomes. So there is a way. And one of the ways is if we have eliminate the private health insurance company that is really just an administrative burden. We spend so much time and money on administration. Duke Hospital, for example, has more billing agents than they have nurses. So they're paying so that they can bill, but they're not paying for more nurses to provide care. So a lot of the dollars we spend isn't going into healthcare. If we could global budget hospitals so that they were providing the care they needed that needed to be done versus lucrative care. Right now, hospitals focus on procedures and things that make money because it's a for-profit system. Whereas other systems, they focus on providing care. We can provide all these, does being able to provide gamma knife surgery, is that more, it's important, but it shouldn't be at the expense of not being able to treat hypertension and diabetes in the majority of the country that needs it. So if we taxed a small percentage of people's income, and this would be a progressive tax, it would be less than what they're paying now, They wouldn't be paying that deductible. They wouldn't be paying the balance of the employer's bill to the insurance company. You wouldn't have these CEOs and all these multi-million-dollar salaries going to these insurance companies. Plus and the money you'd save from administration would pay for the care for people who haven't gotten care or who are unable to access care. The Congressional Budget Office has shown that we can do this. This isn't magic. It's been done before. But we are a delusional country, thinking that we do everything better when clearly the data shows that we don't. And why this country still keeps believing we do everything better and this is the only way to do it when everybody else is doing, there's something very American that is very dysfunctional with this mindset. And so, but one of the things I will say about when you say the information in these slides, the other thing that's happening is this stuff has never been taught. I had to learn it myself. And now they're talking about eliminating all civil rights education in the school. So things are going to get worse if we don't do something too about educating people. So I just had to add that.
Thank you. Thank you for that. So kind of a follow-up question to that. A number of parts of our healthcare system, private insurance is tied to public programs. For instance, as you know, the ACA programs, Medicare Advantage, the VA and TRICARE going out and going to civilian providers, et cetera, workers' comp program, et cetera. What would happen with single payer to those parts of the private-public partnership that's already in place? Have you thought about that, or is that a big part of what has to change?
That has to change. You won't need that partnership because that partnership is just a middleman. They're not provide. Keep in mind, health insurance doesn't provide care. They deny care. Your doctor tells you what you need to get. And then the insurance says, well, that costs too much or whatever. We're not going to allow you to get that. So if you had a single payer system where the doctor said, this is what you need, say, okay, I'll get my gallbladder out next Tuesday, and they send a bill to the government who pays for it, then it's done. You don't need those other relationships. And all they do is they function as middleman. They contribute to the administrative burden, and it fragments the system. So we don't work together. That was part of the problem with the pandemic. There was no cohesiveness. There was no sense of we need to work together to address this because every hospital was worried about them making money. Every doctor's group was worried about them keeping their jobs. Every other institution was worried about how do they survive in this pandemic. They weren't worried about treating that pandemic. They were worried about still making money.
Okay,
And
thank you for that.
The priority, it's not taking care of people.
Okay, so I kind of understand how that kind of all fits in. This is a little bit more kind of on the ground question. Then I think we'll move on to Hank and his kind of close and such. Healthcare, like many other things in our current life, have been really heavily politicized, starting with, if not before, starting with Hillary Care and on forward. And it seems to be a trigger. We try to bring up healthcare discussions that we think can be productive and engaging. And there's so many kind of red flags that go up for other people that it becomes a non-conversation. Since you've done a lot of work in this single payer area, what do you suggest for leagues that are interested in kind of pursuing this and having meaningful conversations in ways that can be productive and can at least take a little bit of the pressure off the sense of politicization of all of this?
You know, everything in this country is now politicized, unfortunately. If, you know, I think we're going to have disagreement on whether the sky is blue or not. And it's scary because, and part of the problem with the politicization of things is that politicians are beholden to whoever gives them money. And who's giving them money? It's people who want to keep the status quo. And that's where grassroots has to come in. It has to be a grassroots effort. And it has to be the people who are trying to move for change. it's going to be difficult to we have to break down the politicization. I'm not sure how. That's a difficult one, but this whole, it permeates all of society, everything that's being done.
And just one final follow-up question, and that is, what do you see the role of the individual states in moving forward on a single payer initiative of some sort versus a national approach? Do you see some practical advantage in states trying to pursue this more effectively and more quickly than we could ever get at a national level?
Well, you know, what Canada did was they got a national single payer program going province by province. I think that's going to be more difficult here. We couldn't even expand Medicaid to the entire country because there's certain states that will never agree. This country is divided. The South has never not been the pre-Civil War South. It is still the pre-Civil War South. They're just a little bit more quiet about it, but now they're becoming loud. But what I'm saying is that I don't know if we can get all states to ever agree to a single payer without a federal mandate. And I think that one of the things too, that doing it federally will uh, eliminate the administrative burden that presents. It will also decrease the fragmentation, because one of the advantages of a federal thing is that it's like the VA. You can go from New York to California and you're still covered. That's what it is with traditional Medicare. You're covered everywhere. It's the same benefits everywhere. If you're getting a knee replaced, you can go move to where your kids live if you want, so you can recuperate from that with them in their house. So it gives you the liberty to make choices. By keeping it in states, it can further divide. That's what I'm concerned about. It can further divide the movement, but it has to become national to get all the benefits of a single payer program.
Thank you. I'm just going to read what Michelle Famula said to everybody in response to a question. She said, "This is a great question. One important way to depoliticize this issue is for the nonpartisan group, like the League of Women Voters, to lead on healthcare reform." There's Michelle. She's waving down there. I think that's a great segue. Thank you, Dr. Rogers. Really, I've been in healthcare my entire career, and I learned a ton from you in a way that is really memorable, impactful, and meaningful. So thank you from all of us for this. It was wonderful. But I'd like to transition, we've got 5 minutes left, to Hank. He's going to talk about how you can get connected within your own league to a statewide group that's going to be continuing to plug away at healthcare issues.
Thanks, Janet, and thank you very much, Susan, for a very informative presentation. Before I talk about what's on the slide, I just want to say that the term politicization can be taken in different ways. And I think there's a positive aspect, which is democracy. That is, the people have a voice in government. And so that type of politicization, I think, needs to be strengthened to counterbalance the lobbying and the influence peddling aspect of politicization. So I very much agree with Dr. Famula's comment about the league taking the lead. And I think that there's a lot of evidence that the kind of healthcare reform that we're talking about, which is consistent with the league's position on healthcare, and also is best described by the kind of single payer program that Dr. Rogers described for us, is highly popular. So if the voice of the people is going to be heard, we're going to end up with the kind of healthcare system that serves the needs of the population rather than becoming a corporate welfare program or remaining a corporate welfare program. Now, let me talk about the wrap up to this caucus. The co-sponsoring leagues put this caucus together because we felt that it was highly relevant in that the league has had a compelling position on healthcare for 28 years. Inequities in healthcare and in health have grown more and more urgent. And they demand action, and they demand our involvement and our leadership and our participation. And we think that the League should be advocating for equitable, universal care. And we consider that working for that is an integral part of making democracy work. So democracy, of course, is a process, but it's a process that is designed to accomplish something that's socially constructive. And we think that healthcare reform is an excellent example of how working on a specific topic is, in fact, the essence of making democracy work. So we want to wrap up with some action items. The hope is that as the result of your gathering here today, that we can reactivate a statewide League of Women Voters of California Healthcare Committee. There has been such a committee in the past. It's been inactive in recent years. And this would be instrumental in getting our League to become more involved, and our League members and our local leagues and our communities. So we want to expand participation of California League members in healthcare reform. And you're part of that now. And we will be in touch with you because we're hoping that all of the leagues that exist around the state will eventually form their own local league healthcare committees as a way of getting league members involved and raising the points that we want to make to our communities. So we're going to be in touch with you. We're going to set up a statewide Zoom call quite soon. And in the meantime, if you want to contact us, we have two emails, one at the Berkeley, Albany, Emeryville League and one at the Diablo Valley League. And those are shown on the slide, healthcare@, and then the addresses for our two different leagues. You are going to be on our email list. If you want to be dropped from that list, simply let us know and we won't bother you, but we hope to stay in touch. And we look forward to seeing you very soon on a statewide Zoom call to continue the reactivation of the work, the action items that are described on this slide. So thank you so much to all the participants, to the co-sponsoring leagues, and to Dr. Rogers, and to all of you for participating.
Thank you, Hank. Thanks again to Dr. Rogers, and we hope to see you virtually at many other sessions throughout this convention week. Thank you for participating in this. We had about 80 people who attended, so that's wonderful. Hope you enjoy your California convention. Thanks so much. Take good care.
That's somebody out here. It's not my phone. It was somebody's on.
Hi, Janet. Did you see my message? Would you mind responding to me in the chat? My name is Candia Mosley. Thank you.
You bet.